Welcome back and good afternoon everyone. So now we will carry on the lecture, that is crash course in orthopedics for undergraduate students. Now this lecture I am taking on behalf of Department of Orthopedics, ZGS Medical College and KEM Hospital. Up till now we have discussed metabolic bone disorders, bone tumors, joint disorders, and the last lecture was about pediatric orthopedics. Now we will start the next chapter, that is infections in orthopedics. Infections in orthopedics is mainly divided into two types. One are the pyogenic infections, that is infections caused by pyogenic organism. They can infect the bone, osteomyelitis, which can be acute or chronic, or they can affect the joint. So acute septic arthritis. Now the second types of infections important in orthopedics are tubercular infections. Okay, so first we will discuss these pyogenic infections, in which we will be discussing pyogenic infections of bones, that is osteomyelitis, and joints, that is septic arthritis. So let's start with osteomyelitis. Pyogenic or suppurative osteomyelitis. Pyogenic osteomyelitis is infection of bone and bone marrow by pyogenic organism. Okay, so infection of bone and bone marrow by pyogenic organism is known as pyogenic osteomyelitis. Now most of the time whenever you are reading osteomyelitis, you must be reading acute osteomyelitis, chronic osteomyelitis, thinking that these two are different disorders. No, here first I would like to clear the concept in your mind, that this osteomyelitis, whether it is acute or chronic, these acute and chronic are the phases of same osteomyelitis. These two are not different disorders. So what happens if infection of pyogenic organism there in bone, the onset will be acute, that is known as acute osteomyelitis. And if this acute osteomyelitis is treated properly in time, it will resolve. If it is not treated in time, it will go into the phase of chronic osteomyelitis. So acute osteomyelitis and chronic osteomyelitis, these are the phases of same disorders. These are different phases of same disorders. These two are not different pathologies, they are same but in different phase of disorders. Okay, so whenever there is pyogenic infection in bone, there will be acute onset. If you treat the patient properly within time, it will resolve. If you are not treating properly, it will go into chronic osteomyelitis. Now in previous days, usually we differentiated acute and chronic osteomyelitis based on the time duration, and the duration was 4 to 6 weeks. If infection is less than 4 to 6 weeks, we used to call it as acute osteomyelitis. If it is more than 4 to 6 weeks, we used to call it as a chronic osteomyelitis. But now that definition is no more acceptable. Now the definition and differentiation between acute and chronic osteomyelitis is based on formation of sequestrum, dead necrotic bone. If there is infection and sequestrum has not formed, it is acute osteomyelitis. If after the infection sequestrum has already formed, it is considered as pathognomic of chronic osteomyelitis. Okay, so first we will discuss the various organisms causing pyogenic osteomyelitis. And in orthopedics, all pyogenic infections, barring some specific situations, are most commonly caused by Staphylococcus aureus. In sickle cell anemia, it is the salmonella which causes most commonly, and in intravenous drug abusers, here it is important, I would like to specifically mention the incidence of Pseudomonas osteomyelitis increases significantly. Still, the most common organism causing osteomyelitis is Staph aureus. So remember, in some of your coaching classes they are telling Pseudomonas as the most common causative organism for osteomyelitis. No, this is incorrect. It is Staph aureus only, but the incidence of Pseudomonas infection increases significantly. So if in your PG entrance exam, if they are giving Staph aureus, that will be the answer for no doubt. If they have not given Staph aureus, in that case you can go with Pseudomonas. Now, arrival of infection in the bone. The most common type of osteomyelitis is hematogenous osteomyelitis, where primary infection is somewhere else and the causative organism reaches the bone through blood. So hematogenous osteomyelitis is the most common type of osteomyelitis, also known as primary osteomyelitis. Now there can be some causes which can lead to direct entry of organism in the bone, which is known as secondary osteomyelitis. The causes may be penetrating injury, where the injury itself carries bacteria from skin to the bone. There can be direct spread from adjacent soft tissue infection. The classical example is diabetic foot, diabetic ulcer. From ulcer, infection can go into the bone. There may be open fractures or compound fractures, or during surgery. So these are the causes of secondary osteomyelitis. The most common type is hematogenous or primary osteomyelitis. The most commonly affected area in bone is metaphysis. Why metaphysis is involved? There are some causes for that. It is highly vascular area. So more number of bacteria can reach at this place. Along with more number of bacteria reaching this place, the second important factor is this typical hairpin loop arrangement of blood vessels, like hairpins. What happens? This is nutrient artery dividing into descending and ascending branch. Then there is differentiation into arterioles. Arterioles then turn on itself, draining into venules. Then it is nutrient vein. So this hair loop arrangement, what it causes? It leads to stasis of blood, decrease in velocity of blood flow. When there is decrease in velocity of blood flow, more number of bacteria can come out from the blood to reach the bone. They can come out from the blood because blood is flowing slowly in this particular area. As more bacteria are reaching there, because highly vascular, but the blood flow velocity is low, so more number of bacteria can come out this place to infect this metaphyseal area. Once they reach at this particular place, the phagocytic system is not well developed in that area, so they are not effectively killed by this phagocytic system. Okay, so these are the important causes why metaphysis of long bone is involved most commonly. And this acute pyogenic osteomyelitis, it is usually a disorder of children below the age of 8 years. That is why overall most common site for osteomyelitis is metaphysis of long bone. Now in adults, this metaphysis is not as vascular as in children. In adults, the most common site of osteomyelitis is vertebral column, vertebrae, because vertebrae are very vascular. Okay, so overall it is metaphysis of long bone. In adults, it is vertebrae. Now you will see what is the basic pathology. What happens once the bacteria arrives at this particular area? So through blood, bacteria will be reaching at this area and it will cause infection, and as soon as there is infection, it will lead to inflammation, acute inflammation. So the first stage is stage of inflammation, and as there is infection by pyogenic organism, there will be formation of pus. So this is stage of suppuration. Once there is formation of pus, this pus will go along the paths of least resistance. So this pus will go on this side, and especially will come here just below the periosteum. So it will lead to subperiosteal abscess as well as intramedullary abscess. So pus will spread along the paths of least resistance. So there will be formation of subperiosteal abscess. So this is the stage of abscess. Now up to this stage, if you treat it properly with antibiotic or if surgery is indicated, there will be a resolution of the disease. So up to this stage, it is acute osteomyelitis. If it is not treated properly up to this stage anywhere, it will go into stage of chronicity. What will happen? Due to increased intraosseous pressure, there will be defective intraosseous blood supply. Further, periosteal abscess will cause hampering of periosteal blood supply. So what will happen? This area of bone, this will be having no blood supply. So it will be detached from vascularized bone. So this will be dead necrotic bone known as sequestrum. Once sequestrum is formed, it is defined as chronic osteomyelitis. Now after formation of sequestrum, there is drainage of pus through a hole outside the body. It is known as cloaca, and this is the hole in new periosteal bone. Whenever periosteum is stimulated or irritated by infection or tumor, which we have discussed in our first lecture, the cambium layer of periosteum will form bone, like in this osteomyelitis. So there will be new bone formation. It is known as involucrum. So in chronic osteomyelitis, you will find this dead necrotic bone, that is sequestrum, continuously draining sinus through involucrum, and new periosteal bone known as involucrum, and drainage of pus through cloaca. Okay, so this is the basic pathology. Up to this stage of subperiosteal abscess, if you treat it, it will resolve. Here up to this stage it is acute, and if it is not treated properly, it will go into stage of chronicity. Now here you can see very interesting fact. This dead necrotic bone, it is lying in the cavity. It has no connection with vitalized bone. So there is no blood supply to this dead necrotic bone. So neither antibodies nor antibiotics if you are giving from outside. So neither antibodies, that is immune system of body, neither antibiotic from outside can reach at this area, because it is devitalized bone with no connection with vitalized bone, no blood supply. So neither antibodies nor antibiotics can reach this place. That is why this is the preferred site for organism. So Staphylococcus aureus will be residing at this place, because nothing can go there to kill that Staph aureus. That is why if there is chronic osteomyelitis, unless you remove this dead necrotic bone, favorite site for bacteria, you cannot cure it. Therefore, treatment for chronic osteomyelitis is always surgical. Okay, in acute osteomyelitis we can try antibiotic, but for chronic osteomyelitis, unless you are removing this particular area, you cannot treat. Okay, so this is the basic pathology. Now clinical features. In acute osteomyelitis, as there is acute pyogenic infection and there is collection of pus, there will be signs of acute pyogenic infections. Local signs will be pain, swelling, tenderness and warmth, all local signs of inflammation. There will be restriction of joint movement, and in systemic signs there will be signs of pyogenic infection or septicemia, like fever, anorexia, weight loss, tachycardia, tachypnea. So this was about acute osteomyelitis. If it is going into the stage of chronicity, that is chronic osteomyelitis, what will happen? As due to formation of involucrum and cloaca, the pus is continuously coming out from the body. So there is no collection of pus. So signs of inflammation will go away. The typical presentation will be chronically discharging sinus, around which there is puckered scar and there is irregular thickening of bone. pain will be minimal as pus is continuously coming out. For the same reason, there will be no signs of inflammation. So acute osteomyelitis, all signs of infection and inflammation. Chronic osteomyelitis, continuously draining sinus. On investigation, the first investigation usually we do is an X-ray. So in acute osteomyelitis, on X-ray, the earliest X-ray finding will be loss of soft tissue planes. What is that? Normally, if you are taking X-rays, not only bones, the soft tissues also produce some shadow. Here you can see this is normal X-ray, this is tibia, this is fibula. Now this is posterior side. You can see this calf bone, this shadow. This shadow is produced by deep muscular plane, calf muscles. Whereas these less dense shadows you can see, these are produced by superficial fatty plane. So soft tissues also produce some shadows, deep muscular plane, superficial fatty plane. So this definition of soft tissue plane will be lost in acute osteomyelitis at around 24 to 28 hours because of formation of pus and inflammation. There will be edema. So here in infection you can see you cannot make out those soft tissue planes. So loss of these definition of soft tissue planes, this is the earliest X-ray finding. Now the other important fact, though this is the earliest X-ray finding, it is not specific for osteomyelitis because these loss of soft tissue planes will also be seen whether there is soft tissue infection, where there will be inflammation and pus formation in soft tissue, or whether there is trauma to soft tissue where there will be hematoma in soft tissue. So though this is the earliest change on X-ray, it is not specific. Now what is the earliest specific change? That is periosteal reaction, periosteal new bone formation. Here you can see this periosteal new bone formation. This is the earliest X-ray finding which signifies the infection. Okay, so there can be two different statements in your MCQ. Earliest X-ray finding of acute osteomyelitis, that will be loss of soft tissue planes, but it is not specific. So the second MCQ can be earliest X-ray finding of osteomyelitis on X-ray which signifies osteomyelitis, that will be periosteal reaction. Okay, so these are the two important reactions of two important findings on X-ray in acute osteomyelitis. In chronic osteomyelitis, on X-ray you will find these changes only which we have discussed in pathology, that is dead necrotic bone inside the cavity, this is sequestrum. New periosteal bone formation, this is involucrum, and draining sinus either here I think or here, that will be cloaca. So these are the important radiological findings, X-ray finding in chronic osteomyelitis. In acute osteomyelitis, if we are suspecting osteomyelitis and there are no changes, we can do MRI, which is the most sensitive investigation, radiological investigation, most sensitive radiological investigation for acute osteomyelitis, and it will be showing fluid signal before the X-rays become positive. Here you can see as soon as there is infection in the bone in metaphyseal area, there will be inflammatory edema, and that can be detected on MRI as fluid signal, which will be positive around 6 hours after the infection. So it is the most sensitive radiological investigation. On bone scan, you will find increased uptake in infected area. Here you can see, which will be positive after 12 to 24 hours. So in radiological investigations, the first test which is becoming positive is MRI at around 6 hours, which is the most sensitive radiological investigation. Then it will be bone scan, and finally it will be X-ray, which is the least sensitive investigation. Bone scan will be positive in 12 to 24 hours. X-ray will be positive around 24 to 72 hours when there will be loss of soft tissue planes. Okay, So these are the radiological investigation in acute osteomyelitis. But the most sensitive and specific investigation to confirm the diagnosis overall, it is culture and sensitivity of tissue sample or pus taken out from the infected site. This is the diagnostic test, culture and sensitivity. Okay, microscopic examination of that sample and then culture and sensitivity. That is the diagnostic, most sensitive radiological MRI. Okay, so bone scan we have discussed will show increased uptake. Culture sensitivity is the diagnostic test. And in hematology you will find non-specific finding like increase ESR, CRP, WBC count, which is usually seen in all inflammatory conditions. Now we will see treatment. Treatment of acute osteomyelitis. In acute osteomyelitis, if there is no formation of subperiosteal abscess, we start conservative management in the form of antibiotics and supportive treatment, that is rest to the limb, analgesic, proper hydration if patient is dehydrated. This all will be done with antibiotics. If there is no improvement in patient's condition within 12 to 24 hours, or patient is directly coming to you with formation of subperiosteal abscess, in those cases surgical drainage of pus is required. Okay, so if there is no abscess formation, we can try conservatively. If there is abscess formation or patient is not improving within 12 to 24 hours of conservative treatment, surgical drainage of pus is indicated. Now, as opposed to that, in chronic osteomyelitis, where there is formation of sequestrum, as we have already discussed in pathology, sequestrum is the area which has no connection with vitalized bone, viable bone. So there is no blood supply to sequestrum. Neither antibiotics nor antibodies will reach at that place. So you will have to take out that. So in chronic osteomyelitis, always treatment of choice is surgery. You take out dead necrotic bone, you remove all granulation tissue, all devitalized soft tissue, and you close the wound over a drain. The surgery is commonly known as sequestrectomy, removal of sequestrum. It is the basic surgical principle in chronic osteomyelitis. Complications of acute osteomyelitis, chronic osteomyelitis, which is the most common complication. There may be septicemia and metastatic infections to the other side. It can cause brain abscess, lung abscess. So infection can spread hematogenously to cause abscesses at other side. There can be pathological fracture. It can also cause septic arthritis, or if it is affecting physis, it can alter the growth. Complications of chronic osteomyelitis are acute exacerbation. There can be joint stiffness, pathological fractures. There can be sinus tract malignancy. Sinus tract malignancy will be soft tissue malignancy, and most commonly it will be squamous cell carcinoma. There can be altered growth or rarely amyloidosis. So this was about acute and chronic osteomyelitis. Now we will see a different pattern of osteomyelitis known as Brody's abscess. We have discussed as soon as there is infection by pyogenic organism, the onset of disease is acute. But in this typical case, this onset is not acute, rather it is subacute. Okay, this is not acute, rather it is subacute. Because of two conditions: either the infective organism, which is Staph aureus only most commonly, have low virulence, and the immunity of the patient is good. So what will happen as soon as there is infection in this metaphyseal area, because of good immunity and low virulence of infective strain, body tries to contain that infection by forming bone around that infection. So there will be formation of pus surrounded by a zone of sclerosis, which is Brodie's abscess, a type of subacute osteomyelitis. Remember, this is subacute osteomyelitis, not chronic. So there will be localized abscess surrounded by a zone of sclerosis. Most common site of involvement is tibial metaphysis of tibia. Patient may complain of deep pain, and on X-ray, as you can see, there is radiolucent area surrounded by a zone of sclerosis in the metaphyseal area. Treatment will be antibiotics, trial for 3 to 6 weeks. Most of the patients will improve. If patient is not improving with just antibiotic within 3 to 6 weeks, curettage of the cavity with or without bone grafting depending on the size of cavity is indicated. Okay. Now we have discussed pyogenic infections of bone. We'll start pyogenic infections of joint. So septic arthritis. Septic means pyogenic infection. Arthritis means inflammation in the joint. So inflammation in the joint produced by infection by pyogenic organism is known as septic arthritis. So septic arthritis is infection of joint by a pyogenic organism. Route of infection, here also most common is hematogenous arrival. Infectious organism is present somewhere else, reaching to the joint through blood, which is the most common type. Sometimes there may be direct invasion by penetrating trauma or surgery, or sometimes there may be infections in the joint from adjacent metaphyseal osteomyelitis, where metaphysis is inside the joint. Capsular attachment is up to metaphysis. So metaphysis infection can directly lead to infection to joint like shoulder and hip joint. Here also the most common causative organism for septic arthritis is Staphylococcus aureus. Clinical features, most of the time the patient is a child between the age of 4 to 10 years, most commonly affecting knee joint. Once again, in every infection, pyogenic infection, there will be local symptoms and there will be systemic symptoms. Local symptoms will be all signs of inflammation, that is pain, redness, warmth, swelling and tenderness. Along with that, there will be stiffness of joint, reduced movement of joint. And remember, the characteristic feature of septic arthritis is there is gross limitation of joint movement. As soon as you try to move the joint, child will cry immediately. So there is no movement possible in the joint. That is characteristic of septic arthritis. So these are the local findings, and systemic findings of all septicemia, fever, anorexia, weight loss, tachycardia, tachypnea. Okay, so there will be local signs, systemic signs. One very important fact, in early stages of joint infection, up to 12 to 24 hours, there is synovitis only, in inflammation in synovitis. After that, there is start of cartilage damage. So during this portion, when there is only synovitis, limb will be held in the position of ease. What is the position of ease? Joint capsule is pain sensitive structure. Whenever there is synovitis, there is accumulation of synovial fluid in the joint that can lead to stretching of joint capsule. So stretching of joint capsule will cause pain, as joint capsule is a pain sensitive structure. So what will happen? Due to stretching, there will be severe pain. To avoid that, the patient will try to keep the joint in a position where maximum synovial fluid can be accumulated without causing stretching of the capsule. So that position where maximum fluid can be accumulated without causing stretching of capsule is known as position of ease or position of maximum capacity. And that position of ease in knee joint is inflection. In hip joint, it is Faber, that is flexion, abduction, external rotation. In shoulder it is adduction and internal rotation, and in elbow it is flexion and mid prone position. So these are the positions in which the joint will be kept in early stage of infection, that is first 12 to 24 hours, which is the stage of synovitis. After that there will be destruction of joint, then that position will change. Diagnosis. During diagnosis we will do hematological investigations. Once again there will be non-specific finding like raised DSR, CRP, WBC count. Diagnosis will be confirmed by aspiration of synovial fluid from joint and sending it to biochemical as well as microbiological analysis. In biochemical analysis, the fluid will be almost opaque, yellow-green in color with decreased viscosity because of destruction of high uronic acid. And in microbiological examination, gram stain will be positive. Most of the time gram positive bacteria, that is staph, and then we will send it for culture and sensitivity, which is the diagnostic for infection. In treatment, it is always surgical, in contrast to acute osteomyelitis where we try conservative management if there is no formation of abscess. In septic arthritis there is no role of conservative management. It is an urgent surgery, because if within 12 to 24 hours you are not draining out the pus, there will be damage to articular cartilage. So before damage to articular cartilage, before 12 to 24 hours we will have to drain the abscess out of the joint. So we will do urgent washout of the joint along with antibiotics. Now this washout can be either arthroscopically or it can be by open, that is through arthrotomy, opening the joint. So surgical treatment is always required in septic arthritis, drainage and washout of the joint. And antibiotics both in acute osteomyelitis and septic arthritis are usually given for 6 weeks, 2 weeks of IV antibiotics followed by 4 weeks of oral antibiotics. This is the traditional and most commonly used protocol. Nowadays some surgeons also use 4 weeks, that is 1 week of intravenous and followed by 3 weeks of oral. Okay, but most commonly used is 6 weeks. Now its specific type of septic arthritis is Thorne-Smith arthritis, which is acute pyogenic arthritis of hip joint in infancy, children less than 1 year, more specifically less than 9 months. What happens during ossification of femoral head? This epiphysis, there is ossification at around 9 months of age. Okay, so before 9 months this area is completely cartilaginous. If any pyogenic infection occurs before 9 months of age, as this is cartilaginous area, this will be completely destroyed. So what will happen in Thorne-Smith arthritis? There will be complete destruction of femoral head. Acute pyogenic infection of hip joint causing complete destruction of femoral head. The child will be presenting with short limb, and there will be increased movement in all direction because there is destruction of head and there is severe instability. For the same reason, there will be positive telescopy. So this is a specific type of septic arthritis affecting hip joint in infancy. Now, after finishing pyogenic infection, we will discuss the second part, that is skeletal tuberculosis. Okay, tubercular infections. It is always secondary, and the most common primary site from where infection comes to the bone is lung, followed by lymph nodes. So from lungs and lymph node, this Mycobacterium tuberculosis reaches the bone through hematogenous route, either bones or joints. Okay, so this skeletal tuberculosis is divided into following type. tubercular spondylitis or spondylodiscitis, that is tuberculosis of spine, also known as Port's disease, which is the most common type of skeletal tuberculosis. Second is tubercular infections of joint known as tubercular arthritis. And amongst the joint, it is hip joint which is involved most commonly. It can also involve knee joint and shoulder joint. And in shoulder joint, characteristically, there is no formation of abscess. That is why it is known as caries sicca. Sicca means dry, caries means destruction. So there is dry destruction of shoulder joint. Now the third type of tubercular infection is tubercular infection of bones. It can infect long bones like tibia or small bones of hand and feet, where it is known as spina ventosa. So spina ventosa is tubercular infections of small bones of hand and feet. So remember, don't get confused this spina word with spine. Spine tuberculosis is Port's disease. Spina ventosa is tuberculosis of small bones of hand and feet. So we will discuss the most common type of skeletal tuberculosis, that is spinal tuberculosis, also known as Port's disease, which is always secondary and reaches the spine through hematogenous route, and the most common area of involvement is dorso-lumbar junction. In this dorso-lumbar junction, this is the lower dorsal region which is involved most commonly than upper lumbar region. Pathology wise, more than 90% cases, they will have this type of distribution. This lower half of vertebra, intervertebral disc, and upper half of lower vertebra. Lower half of upper vertebra, upper half of lower vertebra, and intervertebral disc. They all develop during embryonic life through same somite. So they have same blood supply. And we have discussed tubercular infection is hematogenous. So it will reach in this area and will affect this. First, intervertebral disc space. There will be destruction of intervertebral disc space. Then adjacent part of vertebrae are involved. Paradiscal. Okay. So this paradiscal type, where intervertebral disc and adjacent part of vertebrae are involved, is the most common type of spinal tuberculosis. The other types which are less common, central, where central part of vertebrae involved, anterior part of vertebral bodies are involved, and there is spread along anterior longitudinal ligament. And the least common type, posterior type, where posterior elements are involved, that is pedicle, lamina, spinous process, transverse process, and facet joints. This is the least common type. Most common type and usual type is paradiscal. Clinically, the earliest presenting symptom is back pain along with back stiffness. Because of pain, there is spasm of paravertebral muscles which will lead to back stiffness. So earliest presenting symptom will be pain and back stiffness. Earliest presenting sign will be tenderness. So what is sign? Which will be elicited by you, by clinician, and symptom will be complained of by the patient. So patient will complain of pain, back pain, and you will examine, and at your examination the earliest finding will be tenderness of spine. There may be deformity, either knuckle, gibbous, or kyphus. Knuckle and gibbous are angular deformity. Here you can see angular deformity, knuckle where one vertebrae is involved, gibbous 2 to 3 vertebrae involved. So if they have this type of deformity, they are angular kyphosis, either knuckle or gibbous. If it is involving more than 3 vertebrae, mostly it will produce this rounded deformity. So this is rounded kyphosis. So these type of deformity can be seen. There can be local swelling when there is formation of cold abscess, And as with other sites of tuberculosis, there may be constitutional symptoms and night pains. If there is compression of spinal cord or other neurological structure, that is nerve root, there may be neurological signs. And the earliest neurological sign is ankle clonus and increased deep tendon reflex. On X-ray, the earliest X-ray finding, remember here also earliest X-ray finding which is mentioned in all standard textbook of orthopedics and radiology, it is reduce or loss of disc space. Here you see this is intervertebral disc space, here it is in tuberculosis. So reduction in intervertebral disc space, it is the earliest radiology X-ray finding which is specific for tuberculosis. There may be straightening of spine because there is spasm of paravertebral muscles. It will lead to straightening of spine with loss of spinal curvatures. There will be osteopenia due to infection and erosion of adjacent disc margins. Due to formation of soft tissue abscess, there can be bird nest abscess. You can see here fusiform or bird nest abscess in the shape of bird's nest, or there can be tense globular abscess like this. One important sign known as aneurysmal sign, where there is erosion of vertebrae from anteriorly by enlarging abscess, and it looks like that the bone is eroded by pulsating aneurysm. That is why it is called as aneurysmal sign. There is resorption due to enlarging abscess, which looks like that it is eroded due to pulsating aneurysm. That is why it is known as aneurysmal sign. MRI is the investigation of choice, radiological investigation of choice, which will show here you can see paradiscal lesion compressing the spinal column from anterior side. But the most confirmatory is always tissue specimen. So tissue biopsy under CT guidance is the diagnostic procedure of choice, where you take out the tissue from this area under CT guidance and then you do various investigations for tubercular bacteria. That is the diagnostic, but that is not required in every case. If clinically and radiologically we are suspecting tuberculosis, we start anti-tubercular drugs. If patient is not responding, then we go ahead with this biopsy to see for culture sensitivity and to further confirm the diagnosis. In treatment, very commonly used in India is middle path regime. What is middle path regime? Middle path means we are taking a path which is middle between conservative and surgical. Neither we are too conservative, neither we are too aggressive. So neither we are too aggressive to go ahead with surgery immediately, neither we are too conservative that we are continuously treating conservative. We take middle path regime where we start with conservative treatment, and as soon as there is any indication for surgery, we do surgery. So we will start with conservative management with strict bed rest and anterior tubercular drugs. If patient is improving, after 2 to 4 weeks, we start mobilizing the patient with the help of Taylor's brace, and we will be doing physiotherapy. If surgery is required, there are the indications. Patient is not improving on conservative treatment. If neurological deficit is increasing in severity, if there is involvement of bladder and bowel, or if there is severe deformity, severe kyphotic deformity, if any of these indications is there, we'll go ahead with surgery. Sometimes tuberculosis of spine, that is sports spine, can lead to paraplegia, which is known as sports paraplegia. Okay, so paraplegia caused by tuberculosis of spine. It is more common in tuberculosis of dorsal spine because spinal canal is relatively narrow in dorsal spine with more neural structure. Blood supply is precarious, particularly in area of D4 to D10, and spinal cord terminates at L1 level. So if the lesion is below L1, it will compress nerve roots only, not the spinal cord. So paraplegia to occur, there should be compression of spinal cord which is ending at L1 level. So tuberculosis at L1 only will compress the spinal cord in lumbar area, and in dorsal area at all level it will compress spinal cord. So that is why paraplegia is more common in tuberculosis of dorsal spine. The Sedons classify this paraplegia into two types. Early onset, where paraplegia occurs within 2 years of disease onset, and late onset, where paraplegia occurs after 2 years of disease onset. And this early onset paraplegia is associated with active disease, that is, active tubercular infection is present. Therefore, it has very good prognosis because active infection you can control easily. If it is healed like in late onset paraplegia, so there is nothing to control. You will require surgery only. Okay. So early onset is due to active disease, late onset with healed disease, some of the mechanical cause. Now in early onset, causes are compression by tubercular abscess or inflammatory edema, granulation tissue or caseous material. So all signs of active infection, and any of these will compress spinal cord leading to paraplegia. Whereas in late onset, it is either due to prolonged stretching of cord over kyphotic deformity. See, this is kyphotic deformity, cord will be like that. So it is stretched for long time over kyphotic deformity. There may be stenosis of vertebral canal, or there can be infective end arthritis causing ischemia of cord. So these are the types and causes of POTS paraplegia. Early onset has good prognosis because associated with active disease. Late onset has poor prognosis because it is associated with healed disease, and paraplegia is due to some mechanical factor. Now, clinical features and stages. Most of the time, POTS paraplegia has gradual onset, and as it is upper motor neuron type of lesion, it will be spastic type of paraplegia. Earliest sign of this paraplegia will be ankle or patellar clonus. Other early sign will be exaggerated deep tendon reflex and upgoing plantar reflex, that is positive Babinski's sign. POTS paraplegia progresses through 4 stages. The earliest stage is muscle weakness, and this muscle weakness is spastic muscle weakness. Okay, so in this stage, patient usually does not have any idea, any awareness about muscle weakness. But as there is spasticity, as soon as patient tries to walk, there will be unsteady gait. So in this stage, clinician can find these signs of upper motor neuron lesion, that is ankle or patellar clonus, exaggerated deep tendon reflex and upgoing plantar. So here clinician can elicit all these signs. The next stage, if patient is not treated, is paraplegia in extension. There will be spasticity and all joints will be in extension. The next stage will be paraplegia in flexion. There will be spasticity but joints will be in flexion. And finally, there is inhibition of all transmission in spinal cord across that particularly affected segment. There will be complete flaccid paraplegia. If there is complete flaccid paraplegia in tuberculosis of spine, that is very poor prognostic indicator. That means it is the last stage in tuberculosis of spine. Treatment, once again, start with conservative treatment, bed rest, immobilization and AKT. If patient is improving neurologically, there is recovery in neurology, we carry on conservative treatment and gradual mobilization till complete recovery. If there is no recovery on conservative treatment or patient is worsening on conservative treatment, or if neurological deficit is going into higher grade, increasing in severity, or there is involvement of bladder and bowel, in that case surgery is indicated. And surgery both for POTS paraplegia or POTS spine without paraplegia. The basic idea of surgery is same as you have seen. This is the vertebral body, this is MRI, this is vertebral body, and this is posterior element. The compression is from anterior side. So there is compression of spinal cord from anterior side. So basic principle of surgery is to decompress the cord from anterior side, remove all dead necrotic bone, drain its cold abscess and decompress the cord from anterior side, because compression is from anterior side. But this is the basic principle of surgery. You will be doing in all surgery. However, approaches to do that can be different. So what approaches can be used? Anterior approach, where we go directly from anteriorly. Anterolateral approach. Nowadays the most preferred approach is all posterior approach. We don't go anteriorly at all, because in these approaches, anterior or anterolateral approach, these are very morbid approaches. Here the removal of ribs is required. We will have to split the pleura and we will have to retract the lung. These are very morbid procedures. So nowadays we don't use these procedures. Nowadays only all posterior approach is used, where we go anteriorly through the pedicle and we decompress the cord, and then posteriorly to provide stabilize the spine, we fix it with these screws and rows, Moss Miami system. Okay, pedicular screw. Now here I would like to mention, in some of the coaching classes which you might have joined, they are teaching that we don't use posterior approach, because as their argument is that whenever we are going posteriorly, anteriorly already there is damage. If we will do surgery from posterior side, we will cause instability of spine. But nowadays that principle is not followed. Here I am showing you the X-ray also. You can see this is from posterior side only, because this procedure is less morbid and further stabilization can be done by implant. So nowadays through posterior approach only, all posterior approach only, whenever possible we decompress the cord from anterior side. Through the pedicle we go anteriorly, we remove all dead bone, drain cold abscess, we remove granulation tissue, decompress the cord, and posteriorly for stabilization we fix it. So remember this thing, don't get confused. Nowadays we go through posterior approach, we decompress anteriorly, okay, and then we fix posteriorly to provide stabilization. Okay, so we have finished our chapter infections in orthopedics. If any one of you have any query, beta, you can ask, then we will proceed to next chapter, that is spine. Yes beta, anyone? Okay, so let's start with spine. Spine, also known as vertebral column or backbone, it consists of two elements, skeletal elements and soft tissue elements. In skeletal elements we have vertebrae, and in soft tissue elements we have two parts. One is neural element, that is spinal cord and spinal nerves with their nerve roots. We have intervertebral disc, and we have various ligaments: interspinous ligament, supraspinous ligament, intertransverse ligament, ligamentum flavum. Okay, so these are the parts of vertebral column. Now in vertebral column we have 7 cervical vertebrae, 12 thoracic or dorsal vertebrae, 5 lumbar vertebrae, 5 sacral vertebrae, and 4 coccygeal vertebrae. So total number of vertebrae are 33. Now between these two vertebrae at each level there is exiting of one pair of spinal nerve. We have 31 pairs of spinal nerve. We have 33 vertebra but 31 pairs of spinal nerve, because the first pair of spinal nerve exits between skull and C1 vertebra. So here in cervical spine we have 8 spinal pairs. So at this level we have plus 1 pair of spinal nerves, and the last pairs of spinal nerve are of coccygeal vertebra. We have 4 coccygeal vertebra but we have only 1 pair of coccygeal spinal nerve. So here we are minus 3. So plus 1 minus 3 minus 2. So 33 vertebrae and 31 pairs of spinal nerves. Now we have intervertebral discs, which are normally 23 in number. First intervertebral disc is between C2 and C3. There is no intervertebral disc between C1, C2. And the last intervertebral disc is normally is between L5 and S1. So we have total 23 numbers of intervertebral discs. Now first we will discuss traumatic part in spine, spinal injuries, and along with mechanism we will see types of injuries. In the spine, most commonly injured part of spine is cervical spine, followed by dorso-lumbar area. More than 50% injuries in spine are in cervical spine. Okay, so mechanism of injuries are flexion injury, where there is sudden flexion of spine, which is the most common type of injury, and most common area in flexion type of injury is cervical spine, particularly lower cervical spine, C5 to C7. And sudden flexion will lead to compression of anterior half of vertebra. Okay, so there will be wedge compression type of fracture, most common in C5 to C7 region. In lower spine, it is common at dorso-lumbar junction, L1 followed by L2 followed by D12 in that decreasing order of frequency. As only anterior column, anterior half of vertebra is involved, these are stable fractures. The second type of injury is vertical compression axial loading, like falling on the head without any flexion or extension. So there is, without any flexion and extension, there is axial loading leading to bursting of vertebra, burst fracture. So there are so many comminuted fragments, and some of them can go into the spinal canal, causing neurological deficit. So this retropulse fragment, which is going into spinal canal, which can cause neuro deficit. And most common area where this vertical compression type of fracture, burst fractures are seen are dorso-lumbar junction. Because as you can see, cervical spine is very mobile area. As soon as there is axial loading, there will be some flexion or extension. So isolated axial loading is less common. Whereas in dorsolateral area, mobility of spine is restricted. Isolated axial loading is more common. That is why this burst fracture is particularly common in dorsolateral area. And this type of fracture is unstable fracture, as anterior as well as posterior half of vertebra are involved. The next type of mechanism of injury is flexion compression, where along with flexion there is some compression on anterior side, which will lead to this teardrop fracture. Here you can see teardrop fracture, more common in cervical spine because flexion extension are more common in cervical spine. Similar to flexion injury, there is extension injury, where sudden extension can lead to avulsion from anterior inferior part at the site of attachment of anterior longitudinal ligament. This is known as extension teardrop fracture. This is teardrop fracture due to flexion compression, and small fragment avulsion fragment, it is extension teardrop fracture due to avulsion by anterior longitudinal ligament. It is also more common in cervical spine. Once again, flexion extension are more common in cervical spine. The next injury is whiplash injury. There is sudden hyperextension followed by sudden flexion. So mechanism of injury, sudden hyperextension followed by sudden flexion. Here there is no injury to bone, only injury to soft tissue elements are there, ligaments and spinal cord. That is why it is also known as neck sprain, as there is no bony injury. So here X-ray will be normal. Whatever you will find on MRI. Here you can see red damaged area on MRI. So X-ray will be normal, and you can see soft tissue injuries on MRI. Now it is also more common in cervical spine because flexion extension is more common in cervical spine. The next type of injury is flexion rotation injury, and whenever there is rotation, what will happen? The facet joints will be getting dislocated. Rotational injury. So there is dislocation of facet joint, and most common area is C5 C6 level, and in dorsolumbar region it will be D12 to L1 level. And any dislocation in body, whether it is in spine or joints, it requires urgent reduction. If close reduction possible, close reduction. If it is not coming by close methods, open reduction. Next mechanism of injury is avulsion of spinous process due to sudden violent contraction of paraspinal muscles, also known as Clay-Shawler's fracture. Most common is in spinous process of C7. Here you can see Clay-Shawler's fracture, spinous process fracture of C7 vertebrae. Other common sites are C6 and T1. So it will be around cervico-dorsal junction. And final type of injury is flexion distraction seat belt injury, where there is excessive flexion in spine will lead to compression on anterior side, flexion injury on anterior side, and distraction on posterior side. So what will happen? First, there will be fracture around spinous process. It will go anteriorly to vertebral body, and anteriorly there is compression fracture. So this type of injury is known as seat belt injury. This injury was common when we used to use seat belts which were there at abdomen only. Nowadays we use those across seat belts. In those type of seat belts there is no flexion distraction injury. So these type of fracture are known as chance fractures, and most common area is dorso-lumbar junction, upper lumbar followed by lower thoracic region. So these were the types and mechanism of spine injuries. All spine injuries are more common in cervical spine except two. One is vertical compression, pure axial loading. Second is car seat belt injury, flexion distraction injury. These two are common at dorsolumbar junction. All other injuries are more common in cervical spine. Now quickly we will see 2-3 important types of specific injuries on which they can ask you short note in your exam. One is Jefferson's fracture, where there is injury to ring of atlas, anterior ring as well as posterior ring. It is a type of vertical compression type of fracture, axial loading causing busting of anterior as well as posterior ring of atlas. As these fragments are going posteriorly and anteriorly, and spinal cord will be there in this area in atlas, so there will be no compression of spinal cord. Everywhere else in bust fractures, in axial loading, there is compression of spinal cord. Here you can see everywhere if there is fracture in vertebral body, bust type of fracture, axial compression, this fragment will go, retropulse fragment will cause compression because spinal cord is behind this vertebral body. Whereas in atlas it is exception, spinal cord is inside this ring of atlas, so there will be no compression of spinal cord even though there is bust fracture. So there will be no neurological deficit. On X-ray specific view, open mouth odontoid view, where you can see normally the lateral border of atlas and axis, they are coinciding. Whereas in Jefferson's fracture, here you can see it has come laterally. So this is open mouth odontoid view. CT scan is diagnostic. Treatment for undisplaced fracture where transverse odontoid ligament is intact, we use hard cervical collar. In displaced fracture, if displacement is more than 7 mm, that means this transverse odontoid ligament is damaged. In that case, nowadays we usually prefer surgery. We fuse C1 with C2. The surgeons who are not operating, they can use halo waist immobilization, halo in the skull and waist support and immobilization, but it will require for 3 months. That is why nowadays we use C1 C2 fusion and we can mobilize the patient early. Here you can see. The second type of fracture in cervical spine is hangman's fracture, where there is bilateral fracture in pars interarticularis or isthmus of C2. What is pars interarticularis or isthmus? It is the area of vertebra between superior articular facet and inferior articular facet. Here you can see this is the superior articular facet of this vertebra, this is the inferior, and this area, this is isthmus. And in hangman's fracture there is break in this isthmus part or pars interarticularis of vertebrae. This is caused by hyperextension injury with compression. Okay, so what will happen due to fracture in this pars interarticularis? This C2 will displaced over C3. So there will be spondylolisthesis of C2 over C3. So there is spondylolisthesis of C2 over C3. For undisplaced fracture, we use rigid orthosis, and for displaced fracture, open reduction and stabilization is required. The next topic is prolapse intervertebral disc. First, see briefly anatomy of an intervertebral disc. It consists of two parts. The central large part is nucleus pulsosus, which is gelatinous part, and peripheral part, which keep this gelatinous part in place, is annulus fibrous. In disc prolapse, what happens? There is some defect in this annulus fibrosus, and this nucleus pulsosus part will bulge, and it will cause compression of neurological structures in spinal canal. So there, disc prolapse is herniation of intervertebral disc into spinal canal with or without neurological compressions. Most common area of disc prolapse is L4, L5 and L5S1. More than 90% of discs are at this level. In cervical spine, it is C5, C6 and C6, C7 level. Here are the stages through which this disc prolapse will progress. The first stage is stage of disc degeneration, where there will be desiccation of disc. Okay, there will be decrease in water contents, disc will become hard, but annulus fibrous is still intact. And nucleus pulsosus is in place. Slight bulge is there. Bulge will be there in the disc. The second is prolapse, stage of prolapse, stage 2, where this nucleus pulsosus is coming into spinal canal, but overlying annulus is still intact. Stage 3 is extrusion, where there is break in overlying annulus fibrous and this nucleus pulsosus is coming into spinal canal. And final stage is stage 4, where there is sequestration. This nucleus pulsosus detaches from primary mass and it comes into spinal canal to compress other structures. So in sequestrated disc, the disc material has no attachment with the primary disc, whereas up to the stage of extrusion, there is attachment of prolapse part to the original disc. Now, which nerve root can get compressed? To understand better, you should have idea what is exiting root and what is traversing root. At each vertebral level, we have exiting root. For example, at L4, L5 level, we will have L4, which is exiting root. So it will be just going below this pedicle. Here, this is the pedicle. It will go out. So at L4, L5 vertebra, the exiting root is L4 and it will come here. The traversing root, which is most related to intervertebral disc, will be L5. So what will be happening? L5 will be coming and exiting at L5S1 level. So L5 will be traversing nerve root, L4 will be exiting nerve root at L4, L5 area. Now most of the time, disc prolapse is paramedial or paracentral, slightly lateral and posteriorly. So what will happen? It will compress traversing nerve root most commonly. Here you can see this traversing nerve root will be compressed most commonly. Sometimes, very rarely, when there is far lateral disc, extreme lateral disc, in that case it will cause compression of exiting nerve root. Okay, so exiting nerve root will be compressed only in some of the cases when there is far lateral disc. Most common type, paramedial or posterolateral disc, there is compression of traversing nerve root. Now you can see at L4, L5 level, L5 nerve root will get compressed. At L5 S1 level, it will be S1. So it is the lower part, which is the traversing nerve root, which will be compressed in intervertebral discs. Okay, so clinically most of the patients are young, in the age group 20 to 50 years. There will be sudden onset of acute back pain. Sometimes there may be history of sudden bending or sudden lifting of weight. Later this acute back pain decreases in severity and there is pain, radiating pain in the distribution of compressed nerve root. So it will start with acute back pain, but it will end with radiating pain. Back pain will become lesser in severity. And if there is prolonged compression of neurological structures, there may be neurodeficit. And type of neurodeficit will depend on the level of disc. And we have discussed at L5-S1 level, the traversing nerve root is S1. So L5-S1 intervertebral disc prolapse will compress S1 root, which is the major nerve root for plantar flexion of foot. So if this nerve root is getting compressed, the muscle weakness will be of plantar flexion of foot. There will be sensory loss over lateral side of foot and on the sole. S1 root is the most important root for ankle jerk. So in L5-S1 root and intervertebral disc prolapse, there will be sluggish ankle jerk. In L4, L5 disc prolapse, this L5 nerve root is the traversing nerve root, which is the major supply to extensor hallucis longus. So there will be weakness of extension of great toe. Sensory loss will be there on dorsum of foot and lateral side of leg. In L3, L4 nerve root compression, intervertebral disc level, L4 root will get compressed, which is the major nerve root for tibialis anterior or dorsiflexus of the foot. So there will be weakness of dorsiflexion of the foot. And in this disc, as there is weakness of dorsiflexion of foot, there will be foot drop. So patient will be walking with high stepping gait. Sensory loss will be there on medial side of leg, and it is the major root for knee jerk. There will be affection of knee jerk in L3, L4 intervertebral disc prolapse. Clinically, the most commonly used test to diagnose intervertebral disc is passive straight leg raising test, where in supine position the clinician raises the leg in extended position of knee. If there is prolapsed intervertebral disc between the range of 30 to 70 degree of elevation, patient will be having similar symptom as he or she is complaining of. That is positive passive straight leg raising test. On raising the leg with knee extended position, there is reproduction of same symptoms which the patient was complaining of. That is passive SLR. Now the second test is Lesigue's test, which is a modification of this straight leg raising test. Here in this test, we start in flexed position of knee and hip, and then we do extension of the knee joint to put stretch on sciatic nerve. This is Lesigue test. This is passive straight leg raising test. These tests, clinical test for prolapsed intervertebral disc. MRI is the investigation of choice to diagnose prolapsed intervertebral disc, and as you can see here in this image, there is prolapsed intervertebral disc compressing the spinal cord from anterior side. Treatment. First episode treatment is always conservative, and if you give proper treatment, more than 90% of patients with first episode of prolapsed intervertebral disc will improve with conservative treatment. We give 3 to 5 days of bed rest. We give anti-inflammatory along with muscle relaxant, and after that we start gradual physiotherapy. Indications for surgery are failure of conservative treatment. If patient is developing neurological deficit on conservative treatment, or patient is coming with coda equina syndrome, which is a surgical emergency. The surgery of choice is discectomy, that is removal of prolapsed part of the disc. The next topic in spine to discuss is spondylolisthesis. Before going with spondylolisthesis, I would like to mention 3 similarly looking terms. In my UG days, I always used to get confused between these terms. One is spondylosis, one is spondylolysis, and one is spondylolisthesis. So what is spondylosis? Spondylosis, in our last lecture of joint disorders which we have discussed, spondylosis is nothing else but the osteoarthritis of spine, degenerative changes in the spine. So here will be decreased intervertebral disc space and formation of osteophytes, like osteophytes in knee. So this is spondylosis. So spondylosis simply means osteoarthritis of spine. Now spondylolysis. Spondylolysis means break in isthmus or pars interarticularis of vertebra. Here you can see this part. If there is break in this pars interarticularis or isthmus, it is known as spondylolysis. If due to this spondylolysis there is slipping of one vertebra over other, here it is spondylolysis, and here it is slipping of one vertebra over other, it is known as spondylolisthesis. Okay, and most of the time this spondylolisthesis is anterior. The upper vertebra is going anteriorly, which is known as anterolisthesis. Sometimes, very rarely, it may go in backward direction posteriorly, known as retrolisthesis. But anterolisthesis is the most common type of spondylolisthesis. Now on X-ray you can see there is decreased intervertebral disc space, bone is sparse. So this is spondylolysis or degenerative changes. Here you can see break in pars interarticularis, but there is no slippage of vertebra. So this is pure spondylolysis. Now in this X-ray there is spondylolysis and this vertebra is slipping over this vertebra. So this is spondylolysis along with spondylolisthesis. Now there are following types of spondylolisthesis. The most common type is isthmic or lytic, where there is primary defect in pars interarticularis or isthmus of body which is very weak, which can either break spontaneously or with trivial trauma, leading to break in pars interarticularis and spondylolisthesis. And this type of spondylolisthesis is more common in L5-S1 area. The second type of listhesis is dysplastic. There is dysplastic facet joints at L5-S1 level. Here, these joints are dysplastic, leading to instability and spondylolisthesis. So there is defective development of joints. Now, third type is degenerative. As the name is suggesting, degenerative means spondylolisthesis developing in spondylotic spine, where there is primary degenerative changes in facet joints. Here you can see. So this will lead to spondylolisthesis, most commonly L4 over L5. See, this is L4 over L5. Most common type overall is L5 over S1, which is isthmic and dysplastic. And in osteoarthritis of spine, in spondylosis of spine, the most common is L4 over L5. Other causes or types of spondylolisthesis are pathological, where some pathological process like inflammation or bone tumor will cause destruction of isthmus leading to spondylolisthesis, or traumatic. The classical example is hangman's fracture, where there is break in pars interarticularis of C2 axis with spondylolisthesis of C2 over C3. So in his hangman's fracture we have spondylolysis of C2, that is break in pars interarticularis of C2 bilaterally with spondylolisthesis of C2 over C3. So this is hangman's fracture. Clinically, patient will be presenting with back pain. There may be claudication and weakness if there is compression of neurological elements. there may be palpable or visible step of just above the level of slip. So if you are palpating like this, here you can see in this area. So here if you are palpating, there will be sudden step off, which is the classical clinical finding. There may be neurological deficits also. And overall most common location which we have discussed, L5 over S1. On investigations, the first investigation which we usually recommend is lateral X-ray. And on lateral X-ray, we grade this spondylolisthesis into 5 types depending on the degree of displacement in comparison to lower vertebra. The width of lower vertebra is divided into 4 equal quadrants: 25%, 25%, 25%, 25%. If the upper vertebra slip is less than 25%, up to here it is grade 1, less than 25%. If between 25 to 50%, grade 2. 50 to 74%, grade 3. 75 to 99%, grade 4. And grade 5, complete spondylolisthesis. The upper vertebra is coming anterior to lower vertebra, more than 100%. This is also known as spondyloptosis. On oblique X-ray, normally this pars interarticularis area, it looks like the neck of a Scottish dog. This is superior articular facet, this is inferior articular facet. So on oblique X-ray, this area, pars interarticularis area, it is neck of Scottish dog. If there is spondylolysis, that means break in this area, it will look like Scottish dog wearing a collar. Spondylolysis. If there is spondylolisthesis, this vertebra is slipping. So what will happen? There will be complete break in the neck. So beheaded Scottish dog in spondylolisthesis, separation of head from neck. Okay, just break, Scottish dog wearing a collar. Spondylolisthesis, beheaded Scottish dog. On anterior-posterior X-ray, you will find this Napoleon hat sign. And to confirm diagnosis, you can go ahead with CT scan and MRI. Treatment, we have discussed on lateral X-ray. We divide these spondylolisthesis into 5 grades. Type 1 and 2 usually we treat conservatively with physiotherapy. If patient is improving, we carry on. If not, then we will do in situ fixation of spine, in situ fixation of that particular area of spine. If it is grade 3, 4 or 5, that is more than 50% slip, always surgery is indicated, and in these cases we try to reduce that slip. Okay, in grade 1 and 2 we can fix in situ, but more than grade 2, more than 50% slip, we first reduce that slip and then we fix it. Reduction followed by fixation. Now we will discuss important spinal deformities, scoliosis and kyphosis. Normally in the spine there are curves only in sagittal direction, antero-posterior direction. Cervical spine and lumbar spine is kyphotic, have convexity anteriorly, whereas dorsal spine and sacral spine are kyphotic, convexity posteriorly. So cervical spine, lumbar spine, lordotic, convexity anteriorly. Thoracic spine, sacral spine, kyphotic, convexity posteriorly. So this is in sagittal plane. In coronal plane, spine is straight. There is no curvature in spine in coronal plane normally. What happens in scoliosis? There is appearance of curvature in spine in coronal plane, giving rise to either C-shaped or S-shaped deformity of spine. And the direction of scoliotic deformity is defined by the convexity of curve. Here it is on right side, convexity on right side, so it will be right sided scoliosis. Now scoliosis is usually divided into two types. One is non-structural scoliosis, which is compensatory scoliosis. There is some pathology outside the spine to which spine is compensating by creating scoliosis. So that is temporary scoliosis. As soon as you correct that problem outside the spine, that compensation will go and scoliosis will disappear. So there is no structural problem in the spine itself leading to scoliosis. So there is no vertebral rotation also. The second type is structural or permanent. There is some structural defect in the spine, and this defect, this scoliotic curve is permanent. One second, beta. This is going to be discharged. Okay. So this structure is permanent. There is some structural defect in the spine, and it is associated with rotation of vertebrae, and it will not disappear on forward bending or suspending the patient. Now first, non-structural type. These are due to either wrong postural habit or limb length discrepancy or hip contractures, abduction or adduction contractures, or sciatic scoliosis. Now in this figure you can see this is the normal person, normal posture, equal limb length. If there is limb length discrepancy on this side, this limb is short. So to keep the limb on the ground, what the patient will do, it will tilt the pelvis down. And this pelvis and this spine, they are single unit, they are attached to each other. So as the patient is tilting the pelvis down, there is appearance of scoliosis. So this is compensatory scoliosis. Pathology is outside the spine in lower limb, but appearance of scoliosis. So as soon as you give the compensation, either you put foot raised below the foot, so pelvis will become straight, curvature will go, or you ask the patient to sit down. In sitting position also pelvis will become square and the spine will become straight. So that is non-structural or compensatory scoliosis. Now mainly we are concerned with structural type of scoliosis, which is the permanent scoliosis. And the most common type is idiopathic, more than 80% of cases. Neither there is defect in development of these vertebral bodies or vertebrae, neither there is any neuromuscular problem. Still there is structural problem in spine causing scoliosis. That is why it is known as idiopathic. Depending on the age of appearance of scoliosis, it is divided into infantile, first 3 years of life, juvenile 3 to 10 years, and adolescent 10 to 18 years. This adolescent idiopathic scoliosis is the most common type of scoliosis overall. The second type of structural scoliosis is congenital scoliosis, where there is defect in development of these vertebrae. Here you can see either wedge vertebrae, this half is not developing properly. Here this is hemivertebra, this half is not developing at all, or there is defect in segmentation on one side or defect in segmentation on both sides. So this is congenital type of scoliosis, where there is defect in development of vertebrae. Neuromuscular scoliosis, due to weakness of muscles around the spine, there is appearance of curve. These muscles cannot hold the spine in straight posture. So it can be either in polio, in some of the muscular dystrophy. So these are the important structural scoliosis. Clinically, there will be visible deformity, that is coronal plane curvature of spine. There will be shoulder asymmetry. On convex side of curve, the shoulder will be at higher level, and on forward bending there will be rib hump. What is rib hump? We have discussed in structural scoliosis. Along with coronal plane curvature, we have rotation of vertebrae. This vertebrae is rotated. So what will happen? On one side, the posterior part of rib will become prominent in comparison to other side due to rotation of vertebrae. So if you ask the patient to bend forward, this area, this will be elevated in comparison to this area. So this is known as rib hump. To check this rib hump, we do this forward bending test. Adams forward bending test. Okay, if rib hump is there, that means there is rotation of vertebra, and this is the structural type of scoliosis. Sometimes there may be pain. It is due to associated muscle imbalance. There may be gait imbalance, and in severe scoliosis, in which the diameter of thoracic case decreases, there may be cardiopulmonary complications. Severity of curve on X-ray is measured by Cobb's angle, where the uppermost vertebra of curve is known as upper end vertebra, lowermost vertebra in curve is known as lower end vertebra. A tangent along the upper border of upper end vertebra and a tangent along the lower border of lower end vertebra. The angle between these two, it is known as Cobb's angle. In treatment, mild degree of curves, that is up to 30 degree of Cobb's angle, can be treated conservatively with physiotherapy, with braces, Milwaukee brace or Boston brace. If there is more severe deformity, that is more than 30 to 45 degree, most of the time surgical correction of the curve is required. Now the next deformity is sagittal plane deformity, kyphotic deformity. Normally in thoracic spine we have kyphosis, and Cobb's angle of this kyphosis is 20 to 40 degree. Normal angle is 20 to 40 degree. In thoracic spine, if this Cobb's angle becomes more than 40 degree, it is known as pathological kyphosis. Normally there is kyphosis in thoracic spine, which will be between 20 to 40 degree. But if it becomes more than 40 degree, it is known as pathological kyphosis. Important causes of kyphosis, you should remember: postural, poor postural habits, which is the most common cause. It may be compensatory, when, for example, in ankylosing spondylitis, hips are fused, the patient cannot move the hips. To look at the ground, patient will try to bend the spine to look down, to walk properly. That is compensatory. Okay, some pathology is outside the spine and the patient is compensating at back. Showman's disease, where there is osteochondrosis of ring epiphysis of vertebral body. What happens? The anterior half of vertebra does not develop normally, but posterior half develops normally, and it is for adjacent 2-3 vertebrae. So this will lead to kyphotic deformity. It can happen in ankylosing spondylitis. It can happen in osteoporosis, where there is wedge compression fracture, which is the most common cause in old age. It can also be seen in tuberculosis of spine, which is the most common cause of kyphosis in adults in India. Okay, so we have finished 2 more chapters. Now we are remaining with traumatic part only. So we will take some break and we'll come back, or you want me to continue right now, beta? Yes, anyone want to give advice? Okay, so traumatic part I will take, beta, morning, next Sunday morning. Is it okay with you? So the evening lecture, I think now we have almost completed 6 hours. So it will be, you will be getting bored. So remaining 2 hours lecture I will take next Sunday. I will postpone next Sunday morning, or you want me to take today only, beta? Okay, so we'll come say around 4:30, then we will discuss trauma part. Okay beta, around 4:30 we will finish. So we will finish off orthopedics today only. Full orthopedics for your university exam we will finish off today only. Okay beta, so we'll come at around 4:30. Have your evening snacks, tea, coffee. Once again, okay beta Aishwarya. Okay, after break at around 4:30 I'll come back. Okay, so I'll come at around 4:30. So once again, thank you very much all of you for joining the lecture. See you at 4:30. Best of luck for